So, good morning, dear colleagues. I would like to welcome you, of course, in this seventh edition of the EPOMEC, the one that we did execute in spite of everything that happened in 2020. I'm very, very proud of this. And I would like specifically to welcome you in this amazing session. Cornea hot chair, what would you do if you were me? My case presentation today is about a case of post-keratoplasty astigmatism. Post-keratoplasty healing usually ends with corneal astigmatism. 1 year after surgery, even in the best hands, the usual corneal astigmatism ranges from 1 to 5 diopters, depending on the suture technique and the post-operative course of healing. Femtosecond PKP has dramatically reduced the amount of post-operative cylinder due to the innovative wound designs, less suturing, and smoother post-operative course. But if the patient ends up with astigmatism, how would you tackle it? We have two weapons for the same enemy, either to do an arcuate incisions or to do an excimer corneal ablation. Which one would you use more and which one would you use first? So this is my case of today. He was a 41-year-old male who underwent femtosecond PKP mushroom shape in December 2014 for advanced keratoconus. Surgery was uneventful with the mushroom design of 8.7 by 7.4 donor cut and 8.6 by 7.3 recipient. He had a perfect, smooth recovery, traveled after 2 months. He was on his medications, which I prescribed for at least 6 months post-op. He showed after 5 months with an attack of allograft rejection with a cauda-deuced line, tangential from 12 o'clock to 3 o'clock, and with accompanying suture-related inflammation in the same quadrant. Rejection was treated with topical and systemic steroids under the cover of topical moxiflox for any bacterial suture-related infection. Patients responded well, as they usually do, and signs of both rejection and infection disappeared. But the area of the treated inflammation showed moderate whitish scarring. He was followed up regularly every month for the next 6 months with a very quiet eye and a best corrected visual acuity of 0.7 or 6.9. So his refraction was plus 2.75 with a minus 10 cylinder at 110. The patient was intolerant to hard contact lenses and to spectacle correction, although best corrected visual acuity was 0.7, but he never wore anything that made him see 0.7. So this was just an artificial best corrected visual acuity in the clinic, in the office, which he never saw. In February 2016, he presented to our office seeking a solution. He had an upcoming job interview actually in the United Arab Emirates in Dubai. So this was his pre-treatment oculizer at the time. Everything was very, very quiet, but he had this ginormous amount of corneal astigmatism in the neighborhood of 9 diopters. And we can all see the area of scarring or the area of steepening where the fibrosis was exactly in this area of the cornea. We did a topolizer. In these patients, I do topolizer topography more, and I depend on it more than I depend on the tomography or a pentacam. If the patient has some, opacities or fibrosis, the topography reads much more accurately than the tomography. But again, by doing a topography, this patient had this amount of steepening and fibrosis in the cornea, and his corneal astigmatism with the topography was 8.5 diopters. So we decided to do an arcuate incision on the femtosecond machine, but which nomogram to use? Most astigmatic keratotomy nomograms nowadays are aimed for clear limber relaxing incisions at 11 millimeter diameter, like the Dono, like the Napa, and it's in cataract surgery. We used a combination of McGee, Buzar, and other femtosecond laser machine, namely the intralaser nomogram for a 7 millimeter optical zone. And this was the plan of the arcuate incisions. We relied mainly on 70% of the pachymetry depth, and we relied mainly on the area of the fibrosis more. And as you can see, the larger incision was in the area that had more fibrosis. And this is, of course, an inverted image because this is the capture of the camera under the microscope of the machine. Okay, so we did these incisions, and immediately post-operatively, and by immediately I mean immediately post-operatively, we sent the patient down to do the another topography, and it was showed that he had still 6 diopters of astigmatism, 6.5. He was 8.5, and immediately he became 6.5. Okay. So only 2 diopters of cylinder corrected. What do we do now? Should we open the incisions or should we leave it for a few days? We immediately decided to open the incisions. So we opened the incisions and we lost 3 diopters of topographic cylinder. 4 diopters in manifest refraction. The refraction of the patient became +1 sphere -6 cylinder at 120, and the best corrected visual actually jumped to 1.2 or 6.5. He felt improvement, but he and honestly me wanted more correction because this is 6 diopters of cylinder that usually are not tolerated well by patients. So we decided to tackle the corneal astigmatism with another weapon, the excimer laser. The first decision we had to be made: should we use topography guided ablation or shall we use wavefront optimized ablation, because the best corrected visual acuity was 1.2. The second decision was in a patient with a penetrating keratoplasty complex architectural scar in the form of a mushroom healing and 2 arcuate incisions. Would we do a surface ablation or would we do a LASIK? If we decide on a LASIK, shall we use a femtosecond or a mechanical microkeratome? I would have chosen topography guided ablation with a surface ablation, but the patient was due to travel again in 10 days and he wanted a faster visual recovery, so we decided to go for topography guided ablation with a femto LASIK. This was the plan of the flap and the plan of the ablation overlay. And this is what happened post LASIK. The patient had an astigmatism of around 5.7 diopters of astigmatism and ended up with 2.4 diopters of astigmatism. 1 week post LASIK, the astigmatism was again 2 diopters of astigmatism. So the uncorrected visual acuity now was 0.7 without anything, without any glasses, any contact lenses. And the refraction was sphere -1.75 cylinder at 140. The best corrected visual acuity was still 1.2, but again, this is a refraction that he can wear glasses with and be very comfortable. The patient was satisfied, and so was I, but he asked if he could recommend any further corrective procedure. But my response was that I wouldn't touch this patient again. Uncorrected 0.7, best corrected 1.2 with a very low prescription. So, just a quick resume of this case. The patient started off with 8.5 diopters of astigmatism. We did the arcuate incisions without opening them to the top, and he ended up with 6.7. We opened the arcuate incisions, and it was 5.6. And then we did the LASIK, and he ended up with 2 diopters of corneal astigmatism. So just a quick resume about the nomograms in femtosecond arcuate incisions post-keratoplasty. Lindstrom and Hanna nomograms are the very, very famous, but were developed for native astigmatism and freehand incisions with a diamond knife. Abbey in 2009 developed a nomogram for femtosecond AK based on the Lindstrom, but again for native astigmatism, not for post-keratoplasty astigmatism. Humeric and Wu developed the first FS astigmatic keratotomy nomogram for post-keratoplasty astigmatism. And this is the Hanna nomogram. McGee and Buzard, the one that we used, have shown that the arcuate incision should follow the steep portion of the scarred graft host junction. And this is exactly what we did. Wilkins again showed that the effect of astigmatic keratotomy post PKP was proportional to the magnitude of astigmatism. The more steepening, the more fibrosis you have, the more effect that you would have with less incision. Toronto University nomogram is very, very straightforward and is the most simple. They used paired arcuate incisions centered on the steep axis and placed on the donor side, and is 60 degrees for 6 diopters, 70 degrees for 7 diopters, and so forth. Thank you so much.